All right, good afternoon, good morning, everyone, depending on where you are. This is Ben Miller. I'm Vice President of Regulatory and Scientific Affairs for the Acheson Group, and thank you for joining us for this webinar. I've got Dr. Ruth Petran with me as well, and she'll be presenting on some material about halfway through the webinar. So we're going to split this up and walk through both where we are with COVID, but also talk a little bit about just communicable disease management as it relates to the workforce and what we've learned certainly over the past couple of years relative to COVID. So we are recording the meeting just for housekeeping purposes, and we'll put this on our YouTube channel later for those that might not have been able to join and watch in real time. If we have questions, you can certainly use the Q&A function, and we'll be monitoring those as we move through the presentation as well. So with that, I will get started and head right into the material. Again, I'm Dr. Ben Miller, and I've got Dr. Ruth Petran with me as well today. So what are we going to be discussing? We're going to cover COVID, and obviously, the question on everyone's mind is what's next? We've lived through 2 years of pandemic. Essentially, where are we? What have we learned? And interestingly, I think, what are some of the lessons from the past that we can draw on that might give us a glimpse into the future of where we might be headed, specific to COVID, but also just communicable diseases in the workplace overall. I think, COVID sort of has reframed our thinking in the conversation about employee health and risk management, and whose responsibility does that fall on? Is that the employee? Is that the employer? Is that a mix? What does that look like? We'll talk a little bit about where we think we're headed and talk more about moving from response. I think we've been, as every surge has occurred over the past year and a half, really been kind of in a response mode to more of a risk management mode. And I think you're seeing those conversations happen at the federal, state, and local level as well. And so as employers, really we want to help try to frame that and give some thinking around what are some key data metrics that you can look at and consider, and how do you map those to some of your risk mitigation strategies. And then Ruth will talk about applying some of those COVID approaches to other public health risks that your workforce might face or need to consider, especially specific to those in the food industry. So where are we right now? I find it's helpful in the US to look to the UK sometimes to see where we're headed. The UK has traditionally seen spikes, especially associated with emerging variants, occur earlier than the US, and it's a geographically smaller country. It has really good surveillance, so it gives us kind of a peek into where we might be headed. And so this graph I just pulled this morning, and this data is kind of the most timely data that we have on cases, hospital admissions, ICU capacity or ICU usage, and then mortality as it relates and compares between the two countries. And so when we look at the UK, we see that cases are coming down really kind of at the same rate as they are in the US. I think the question that remains open at this point, and is the water might be muddied a little bit by the new BA.2 variant or subvariant of Omicron, is where do we end in terms of what that ongoing case rate is going to be? Will we return to levels that we saw last summer of very low case rates in the UK and the US, or will that plateau at a different place? And that'll give us some sense of just what's the amount of circulating illness that's going to be present in the population and in the workforce, over the summer. It's likely that, this is not the last variant we'll see. We'll likely see some seasonality patterns emerge, but we may also see another variant emerge that kind of breaks that seasonal pattern, and we'll talk about that in a slide or two coming up. But what we can see is that, the mortality rates, especially in the UK, and to some extent in the US, were lessened for this Omicron surge, although we did experience higher rates of mortality than some other countries did relative to Omicron for a variety of reasons here in the US. Some of our vaccination rates, some of our the age of our population, the general health status of our population overall. All right. So what really have we learned over the last 2 years? One, I think I've tried to break this down into some simple bullet points, but essentially the science has evolved faster than public health policies or communications. And the graphic that I have on this slide actually comes from Japan. Japan, I think, did a good job around public messaging early on in the pandemic. And this is a poster and kind of phrase that came out of Japanese government and public health authorities in 2020, fairly early on in the pandemic, even before a lot of countries had recognized, or the WHO had recognized, that significant form of transmission or mode of transmission of COVID was actually airborne rather than surfaces. So the Japanese government really broke things down into, I think, a simple concept, and that was, avoid closed spaces, crowded places, and close contact settings. And I think that gave their population, a simple set of rules that they could start to manage their daily lives by. And interestingly, Japan didn't institute many of the lockdowns that some other countries had done early on in the pandemic, and saw actually quite low case rates overall. And we'll talk a little bit about that in a couple of slides, why that might have been. But in addition to targeted public health messaging, the population in Japan kind of took this to heart. Apparently in 2020, the 3 Cs became the word of the year in Japan, or for the Japanese population. So it's an example of how getting communications and messaging right and being consistent in that communication and messaging really makes an impact. And I think we're headed towards probably a similar point in time right now, as we've come down off of an Omicron peak worldwide, and certainly in the US. It's an opportunity to really reframe some of the language that we use and some of the thinking that we have in terms of both COVID, but also other communicable infectious diseases that might impact our workforce. Second, we learned that vaccines are effective treatments, and that they were developed in really record time. We went from having not knowing what COVID-19 was to having an effective vaccine in a little under a year. Again, communication and consistency has been critical, and employers did and remain, I think, our trusted source of information as it relates to both COVID mitigation strategies, but also just information around public health in general. So given there's been such a challenge, I think, in terms of public health communication and people's trust in institutions, especially in the US, I think employers do still maintain kind of a unique space in the sense that their employees look to them for valuable and trusted information. And, I think this is an opportunity, especially as we start to move from risk, kind of responding back into this risk management frame of mind, to be thoughtful about both the policies and programs that are put in place, but also the way that that this information is communicated. So I mentioned, around communication, what made one of the biggest differences in terms of the overall infection rate between countries. So this is research that actually just came out at the beginning of February. And heading into the pandemic, interestingly, the US was rated the #1 most prepared country in the world to respond to a pandemic. I think in that context, people were thinking about influenza, but I think when we look at the response going back over the last several years, certainly other countries probably have done better if we sort of look at measures around the number of people infected, or severe cases of illness, hospitalizations, and ultimately mortality associated with this pandemic. So what actually made the difference in terms of reducing infection rates were, when this analysis was done, it looked at a number of different variables, but the variable that actually stood out, there were 2 that made a significant difference in terms of the overall infection rate in a particular country, and that was high levels of government or interpersonal trust. So did people trust what the public health authorities were telling them, and did they trust each other essentially to put in place appropriate risk mitigation measures and follow those? And so I think we saw in the companies that we've worked with since the beginning of the pandemic, that has been there. There has been a high level of trust between the employer and the employee, and that the communication has been good and consistent. And so Well, this research applies to governments. I think there's a lot for companies and employers to think about in terms of how communication probably makes some of the biggest impact in terms of the risk of transmission in the workplace and protecting your workforce. And so this is just a graph or a graphic from that research paper, and there's a link to that in the presentation. So what are some of the lessons from the past? I found this interesting that there was some research that started to emerge in mid-2021 that talked about there was an influenza pandemic in 1889. And before, we've lived with influenza sort of as an endemic disease for about 500 years, or if you look back over history, it's probably how long that people have been living with influenza, or at least that we've got record that people have lived with this, and that there could be pandemics associated with influenza or respiratory illness like that. Interestingly, the pandemic of 1889 was thought at the time to be associated with influenza, but as researchers have gone back and looked at the actual symptoms that were reported during that particular pandemic, and the fact that a large number of animals were also infected, things like horses and cattle, and that's this reference to zoonotic infections, that it's possible that that pandemic was actually caused by a coronavirus as well, and specifically OC43 coronavirus, which now we know just it's one of the causes of the common cold. So if that were to be true, it might give us a roadmap, or at least a glimpse into the future by looking into the past to see where we've come and where we might be headed. So if we look at this figure that comes from the paper that I have referenced here on this slide, you can see, looking at the year 1890, what this is a graph of is influenza attributed death rates in England and Wales. And so they had a pretty good surveillance system in their medical system back then. But what you'll see is that those rates remained elevated and fluctuated fairly significantly year to year up until about the year 1900. And so does that mean that we're going to live with COVID-19 and future surges for the next 10 years? Not necessarily, but it does give us an idea that if this previous pandemic were caused by a coronavirus, that we might see surges that go on beyond a year or two, and may go, the next 3, 4, 5 years into the future. And that is really what a lot of public health experts are anticipating. So, if we kind of break those into 3 scenarios where we may be headed with COVID, the first scenario might be one where Omicron cases decrease and stay really low because so many people have been infected. One estimate is that 2/3 of the US population was likely infected during this Omicron surge. And if that's true, there's certainly a high level of natural immunity within the population just based on people who were recently infected. Another scenario is that a more transmissible and severe variant may emerge, that it evades either existing immunity that you were acquired through infection or through vaccines and causes significantly higher mortality. When we look at the way viruses evolve, that's typically not what we see. What we see is attenuation, which means that something becomes more transmissible but less severe, and that's certainly what we've seen with Omicron. So in that respect, COVID-19 is doing what we would expect a normal virus to do as it evolves. But the possibility remains that we could see a mutation that causes significantly higher levels of severe illness. I don't think that's likely, but it's something that is possible. Probably what is most likely is that we'll see new variants emerge that cause predictable seasonal surges in the US and worldwide, but they don't have to either. We could certainly see a variant emerge that's more transmissible than Omicron and causes another spike in a certain part of the world, and we would see that move around the globe like we've seen other variants like Alpha, Delta, and Omicron be transmitted. The severity will certainly depend on the specific mutations in any newer emerging variant, but what this suggests is that we need to be ready to reinstitute some of the risk mitigation measures that we know work and that we've used in the past. But we don't need to have those in place consistently and constantly all the time. I mean, I think we're all to the point in our daily lives where we've understand and have calibrated risk and the behaviors that we're going to take, in a way that is most comfortable to us based on our individual health condition and our willingness or likelihood to get infected. But as we think about managing a workplace or a workforce, certainly reinstituting some of the risk mitigation measures that we've had in the past is going to be part of that equation, especially if we start to see a significant surge similar to the one that we have just come out of with Omicron. So when might the pandemic be under control? Well, I think we've probably heard a lot of comments around, are we moving to the endemic phase of the pandemic? It's probably too early to tell for the reasons that we've talked about in this slide around some of these scenarios, for example. So what does it mean to be endemic? Essentially means that we are able to predict the pattern of illness within a population at a particular place or a particular time. So when something's endemic, like influenza or the common cold, measles, or malaria, we know roughly how many cases we expect to see and when we expect to see them. I don't know that we're in that space yet for COVID, and we might not be in that space for the next several years. And so that's really where designing systems that can respond to increased levels of illness in the community or increased levels of illness within your workforce really becomes important. So you can kind of quickly add in layers of protection and quickly remove them when they're not needed. So that really gets this concept of moving from response to risk management. So, as the hazard or the likelihood of COVID infections decrease, then those risk mitigation measures can be relaxed. So we don't need to mask necessarily in indoor spaces if case rates are low. We also, don't need to de-densify office spaces or workspaces. I think when we look towards the future, and we're here now, actually, case rates are really going to be a less reliable measure of community infection. And so we need to think about what are some of those other data and track specifically for COVID. So wastewater surveillance is an example that could be useful in terms of looking at emerging clusters within a particular city or community. Now, this data isn't reliably and widely available for every place in the US. And so, it's a tool, or it might be a data metric that you could use if you're in a location where you have a robust wastewater surveillance data in place. And some of that's available on the CDC's website. I think probably in the short to the medium term, new hospitalization rates are the most reliable measure of infection within the community. And the reason for that is because right now, just about anybody that goes into the hospital gets tested for COVID, and those cases will be reported as COVID cases, even if the reason why they're going to the hospital isn't COVID related. So it's a population where we know regular testing and reporting is being done and will be done probably for the foreseeable future. So looking at new hospitalization rates is probably going to become kind of the new case rate tracking. And it doesn't even have to necessarily do with the level of severe illness. It's just the fact that that population is regularly tested. So as employers, or as those responsible for managing COVID in your workforce, what are some options? Another option is to create an internal data measure that you would track. So something, if you wanted to track, for example, respiratory illness symptoms, and develop specific action thresholds depending on what percent of your workforce is out with respiratory illness-like symptoms, then you can reinstate masking or reinstate other control measures if that percentage of the workforce increases to a point where it's suggestive of COVID or even influenza if you're in influenza season. And I think that's one of the key points moving forward, is that we're going to live and exist in a world where we're not just trying to manage COVID, even though it's very infectious. We also have other communicable diseases like influenza and other respiratory viruses that can certainly impact the workforce and be transmitted in that kind of setting. So if you're looking and building data metrics around symptoms, that really puts you on good footing to address some of those risks to your workforce overall. And to that point, testing and screening in the workplace, if that's for COVID or for influenza, using rapid influenza tests, much like we've come to rely, I think, on rapid COVID tests, I think is going to be another important piece of that equation. So that if you have somebody that presents with symptoms, you're able to offer them some tests that they could do on site or take home so that you can have them out for the appropriate period of time and let them back into the workforce as quickly as possible based on testing and screening. So I view that as sort of one of the silver linings of COVID, that we've all become really, I think, comfortable with using rapid, especially rapid antigen tests to look at, is somebody sick with COVID, or to test, when their symptoms have improved, is it safe for them to come back? So now I'm going to hand it over to Ruth to talk about how some of these approaches that we've learned and developed for COVID might be applied to other public health risks as well. And so she's going to walk us through some examples that are specific, especially for those in the food industry. So with that, Ruth, I will turn it over to you, and just let me know when you want me to move the slides.
Yeah, can you hear me?
Yep, sounds good.
Okay. For some reason, I cannot turn my video on. It says the host has stopped it. So I'll just be on audio then, which is fine. Ben gave us a really good background on, where we are with COVID and how we can move beyond COVID. And I think one of the big lessons we can think about is how we apply what we know about COVID to other public health risks. And I'm going to talk about a couple examples where we can do that. Next slide, please. So this is a graphic that I happen to pull from the St. Louis city government site. I think there's lots and lots of them out there related to disaster planning. And for any of us who are in this kind of world doing these kinds of things, we'd be familiar with this. But I think it's worthwhile to keep in mind, because a couple things to note. Typically, we don't expect these to happen, but what we know that they do. So being prepared is really important. And that's going to vary depending on who you are, where you work, etc. But I think what's telling about this graphic is that it's circular, in that it's a continuous process, starting with being prepared to response, moving ultimately to mitigation, but always maintaining some level of preparedness. And I think those are the situations that are most effectively managed when there is such a response in place. So, as we think about this and in this guise of trying to be prepared, we need to think about what are the right risks to manage. And these will be variable depending on where you're coming from. All of these are very valid determinants, again, depending on your particular situation. Is it the risk that causes the most deaths or the most illnesses? But also you need to be thinking about what's going to potentially affect economics or cause the most significant risks to your brand. Perhaps it's a combination of many of these, but the key is that identifying those risks that are most appropriate for your particular situation is key. Next slide, please. Now, the WHO, or World Health Organization, really is founded upon risk. And if we think about the information we can get from WHO, it really is in that framework that's shown here. The idea of having a science-based risk assessment that leads to the development of the right management strategies for managing those and mitigating those risks where possible. But it really all hinges upon communication, that exchange of information, and considering different opinions and stakeholders' positions concerning those risks. Next slide, please. So when we think about risk assessment, we really need to rely on data. and the science to make sure that we're focused on things that are relevant. This has a couple benefits. One is it just keeps us aware and kind of on our toes about what might be coming, but it also means that we will be in a better position to plan for future surges or future occurrences of these risks. It does mean, though, that you need to stay disciplined and alert for when the metrics or whatever it is you're measuring may be changed. Next slide, please. So that we can really effectively move into risk management. Now we have an official definition from the World Health Organization. This process of weighing the right kinds of alternatives, typically related to policy, in light of those risk assessment outputs and making sure the right controls are implemented. But really put more simply, it's identifying those potential risks, doing some degree of analysis, and then taking the right steps to reduce or curb the risk. It sounds easy on paper. As we've all tried to manage the risks that COVID have presented, both in our business and personal lives, it can be really challenging, and this should not be taken lightly. Next slide, please. So here's just a couple of examples. Now these represent the current mask guidance from CDC. I think it's quite likely that these will change. They've indicated that they are working to consider changes to this, but this is what it is today, where they're looking at total new cases of COVID per 100,000 population in the past 7 days. And these metrics are available on health department websites from the CDC themselves, to just talk about when a mask should be worn to protect yourselves. Very numerically focused and, seems to make some sense. Next slide, please. And then some other practical examples that, started out being applied to COVID, but I would argue that these can be applied more broadly as well. For example, this first one is related to a school district who set some building level criteria. So this is per school building related to the wearing of masks. And they elected to do it that specifically versus looking across their whole district to consider the individual occurrences, in this case of absences. And what they've put in place is that if their school has about a 2 times the historic rate of absences and the county that they're in registers more than 50 infections per 10,000 residents, they will reinstate or continue to instate the mask mandates. Certainly that can relate to COVID, but I would argue that you could also apply it to other kinds of respiratory illnesses like the flu, because these metrics are available. The second example relates to a university who adjusted all kinds of things like the wearing of masks, how much surveillance testing they were doing, capacity of rooms on campus, whether certain events could happen, whether people could travel, whether visitors could attend, related to the transmission of cases. And they have a green, yellow, red kind of risk continuum around a number of disease metrics that then enables adjusting these kinds of occurrences as needed. Next slide, please. But I would like to take this further and think about the risks related to norovirus. Now, we should all be familiar with this. It's the top global cause of acute gastroenteritis, causing an estimated 685 million cases. There's a typo in that box, but it's 685. We know that it causes at least half of all outbreaks of food-related illnesses and a cost of at least $10 billion in the US alone. We know that transmission occurs very frequently from one infected person to another. Now, certainly there's a lot of differences between norovirus and COVID, but that reliance on transmission through an infected person certainly is a common common trait. Next slide. Now, this is another one where the evolving science is important to pay attention to enable being prepared, such as these kinds of data which the CDC has published. For example, we think about norovirus being seasonal and with more occurrences in the winter months. And generally that is true, certainly in the person-to-person transmitted cases of norovirus. However, we know that norovirus can also be transmitted through food. And although there is a dip in the warmer months here in this country, it's not as small as that from person to person. So while we could get somewhat comfortable in perhaps thinking less about norovirus in the warmer months here, that may not be the best idea, because we do know that there still is a substantial number of outbreaks that continue to occur. Next slide, please. So what do we know about norovirus from risk analysis? And there has been a lot of study of this illness agent. The reference here is to a risk assessment done by FDA in the past few years. You know, the findings from that were that the cases that were linked with food were often due to contamination by infected employees in retail food settings. The outcome of this risk assessment showed that they could reduce transmission if they excluded illness, excluded employees who were ill when their symptoms first appeared, if they could improve hand washing efficacy, practice no bare hand contact, and proper sanitation of surfaces. Now, what this study did is estimate the mean numbers of infected customers or patrons of a restaurant for different scenarios involving various risk management strategies. And they compared this to the estimate for a baseline scenario representing current practices. The next slides go through some of these data. So if you could advance, Ben, thank you. For example, around the idea of employees working when they are sick, again, using this baseline number of 1, meaning current practices. So the way to interpret this is basically a number less than 1 means that there was an improvement and fewer cases of illness occurred when these particular scenarios were put in place. A number greater than 1 means that there were more cases of illness. And here we can definitely see the impact of an employee working when they are ill, more than 2 times the numbers of infected customers is estimated to occur. When we see that those sick employees exclude for 24 or 48 hours, we see the enhanced benefit of that longer exclusion period. But then we need to balance this against the reality of what we know about food employees. Further work from the CDC has indicated that at least 60% of food employees have worked when they were ill, per their own reporting, and 20% while they're actively suffering various GI symptoms. Now, why do we do that? Or why did they say they did this? Well, people have good intentions, but they also need their jobs and need the income. They perceive sometimes as that illness being not that severe and manageable, and they don't really want to leave their coworkers short-staffed. Next slide, please. We also looked at the work looked at the impact of hand hygiene. Again, numbers less than 1 indicate fewer cases of illness. Here we see that combining a illness exclusion by ill employees along with compliance to hand washing requirements, wearing of gloves, et cetera, had an impact on lessening cases, but also improving the overall efficacy of that hand washing. Perhaps doing things to get an additional 2 log reduction of organisms on the hands had a greater impact, such as physically removing the virus from the hands through the vigorousness of the washing process. Next slide. Next, the study also looked at facility improvements, such as increasing the frequency of sanitation, coupled with a 24-hour illness exclusion. But the reality is we didn't really see much of a decrease in that baseline number. But when there were facility changes actually made, putting in a touchless faucet, for example, a touchless door, or removing the door to the restroom, that coupled with the illness exclusion had a bigger impact on reducing those illnesses. Next slide, please. So then applying this is a matter of taking those general categories and thinking about just what is practical for your particular situation. We saw the role of excluding ill employees at the first sign of their symptoms. This, to me, prompts the idea for symptom screening and wellness checks so that ill employees really don't even get into the workplace. Empowering employees so that they can report symptoms without consequence. And considering this exclusion period of at least 48 hours, offering sick time with pay can play a significant role at encouraging these kinds of behaviors. Certainly thinking about hand wash efficacy, making sure people wash appropriately when they are supposed to and how they are supposed to. We are very familiar with the 20-second hand wash per what we've heard from many sources related to COVID. My hope is that this will continue to be practiced, as I think it can have impact on norovirus incidents as well. Along the same lines, limiting bare hand contact can be helpful. And then not forgetting about sanitation of surfaces, following established protocols, making sure this is done routinely, and also implementing the use of disinfectants when and where needed. Next slide, please.
All right, thank you, Ruth. I know we're going to kind of wrap up here in a minute. So if you do have any questions, certainly welcome to drop those in the QA using that function. And Ruth, I think you should be able to flip your video on. Looks like it is now. So we can see you if there are any questions. To wrap up, I think the important pieces as it relates to COVID and other communicable diseases is to really adopt that risk-focused mindset, and there is an increased awareness around employee health and workplace transmission right now, certainly as people come back to the office or continue to work in manufacturing setting or a restaurant setting, we do know sort of what those risks of transmission are and look like. I think the thing that's been most challenging about COVID in particular, and Ruth ran through a good example of what we know about an illness like norovirus. We have some established metrics. I think for something like COVID, those metrics feel like they're always shifting because the nature of the illness is shifting as well. Vaccines were highly effective at preventing symptomatic illness until they weren't. And, at this point, differentiating between vaccinated and unvaccinated workforce probably doesn't make as much sense from a transmission reduction standpoint. So we have to kind of constantly be updating the science. But to go back to what Ruth was talking about, updating communication as well, really, I think weaving the why into the reason why programs change and picking some really simple metrics to track as well. I think that's going to be key moving forward. And it does create an opportunity to really pick metrics that encompass, I think, a variety of illnesses. So when we talked before on a slide about the respiratory illness rate, that's not necessarily specific to COVID. That can be specific to other respiratory illnesses as well. So next fall and winter, when we start to enter probably a flu season that will likely be worse than we've seen in the past couple of years, just because of the COVID mitigations that were in place, we're going to have co-infection happening in the workplace. So some people will be out with COVID, some people will be out with flu. And so really trying to reduce and manage the risk around workplace transmission and get people back as quickly as possible too, I think it's going to be key. And so that's why symptom monitoring, I think, above all else, is one of the most important things that you can start to build into some of your ongoing programs right now. So encouraging people to share symptoms, encouraging people to get tested too, especially when they become symptomatic, regardless of sort of what the disease is. COVID is certainly the primary focus, but that has additional benefits as well. Making sure that the metrics and measures that we use are, based on the best data and science we have.
we have to look and see, okay, what data are available, what's going to give me the best sense of emerging risk, and then I need to monitor that. And again, I think the challenge is at least with COVID, that's changing in terms of what those most meaningful metrics are. We talked about earlier on, case rates were what we tended to look at primarily. I think we're going to need to see a shift more towards hospitalization rates or other external data measures that are going to give us a better sense of when we might see the risk of infection going up in a particular location. The US is a big country. What we saw with the Omicron surge was it started in the Northeast and moved regionally, into the Southeast, into the Midwest, and then finally into the Western part of the US. We have seen that pattern emerge with other variants as well. Knowing that now and being able to build some of your risk mitigation programs around that does give you the potential for a heads up into, okay, for the next 2 weeks, we're probably going to have to ask people to remask within our facility. And that's the amount of time that we'll have to be masked up to reduce the risk of transmission in the workplace. But starting to think both strategically and then tactically based on the data measures that you identify and want to track is going to be, I think, important. And then, use trusted sources and trusted resources. So some of those can come from academia, some of those can come from government, some of those can come from folks that you reach out to on an individual basis to help you design and plan some of those programs. So each workplace is somewhat unique in terms of who they are, what their workforce is, where they come from, what programs do you have in place to manage and track things like symptoms in your workforce. I mean, I would say if there's one key takeaway from this particular webinar would be, go and find a reliable way to track symptoms within the workforce. And I think find ways to incentivize people to be honest about what their symptoms are. And so if they do need to be out for a period because they're COVID positive or they have they've got a diagnosed case of influenza, that they feel like they can stay out for the appropriate periods that don't present an infection risk to either their fellow workers or potentially to your customers. I think that's one of the key pieces of learning going forward. And when Ruth was talking about norovirus in terms of, the pressure, especially on, the restaurant facing or retail food facing workforce to come and work while ill, I mean, that has a definite risk profile associated with it, both to their colleagues, but also to customers as well. So again, if there's a silver lining, I think with COVID, it's to take some of those learnings, apply them to COVID, certainly, but also apply them to other communicable disease risks that we're seeing in the workforce or that could emerge or that have seasonable and predictable patterns. And so using that data and creating, again, some simple metrics to look at, I think is going to be important. All right. So with that, I think we can move to questions, and we'll just switch the view here and let me know if there are any questions. You're certainly welcome to put them in the QA, but I can put one to Ruth as we wait for others to put any of the questions that they may have in here. But, Ruth, what do you feel like, from a food industry standpoint, and Ruth is, for those that may not also know, is the current president of the International Association of Food Protection. But, when we look at what the food industry has gone through and where it's come over the past couple of years, certainly challenges in terms of workforce and supply chain, things like that. Do you have a sense, or have you heard from the food industry sort of how they're thinking about adapting to, COVID sort of as a new normal, but also just in terms of what we've been talking about, that shift from response to more risk management and risk mitigation?
That's a good one. I think what we have learned through all this is really the resilience that the food industry has been able to demonstrate. Things aren't back to where they were, or may never be back to where they were, in the, say, late 2019 timeframe. There are changes in the kinds of products that are being made. Some product lines have been simplified through SKU rationalizations and so on. And whether it's related to supply chain challenges, which still continue to exist, I think the idea that can be done, not easily per se, but that it can be managed, was certainly in evidence. So I think going forward, realizing that there is flexibility to ebb and flow in relation to these kinds of inevitable challenges will continue to be practiced. Certainly within the food manufacturing plants, some changes needed to be made as far as staggering work shifts and so on where possible. I think some of that may continue as we potentially see, outbreaks of illnesses going forward. But at the same time, I think the industry learned quickly what they needed to do to protect their employees, whether it was, providing personal protective equipment, doing symptom screening, even using barriers where they could. I think the industry recovered and was able to get back to, production levels that were in line with what was needed to be done fairly well. So again, I think it was part of this being open to what's going on and being ready to kind of flex pretty quickly where needed. And I think the whole idea of flexibility and response will continue to be practiced. And there's a lot to be proud of, I think, that the industry has done.
Yeah, and I think one thing that struck me, about the food industry in particular is that, that wasn't like a lot of industry segments where you could sort of disperse your workforce. I mean, to some extent that happened, but, to make food, people need to show up, need to harvest it, move it to manufacturing facilities, make it, and the food industry really kind of led the way in terms of figuring out what some of these risk mitigation measures should be, how they should work, when to put them in place, when they might potentially relax them. We had a comment from one of the attendees that, in Oregon, effective April 1st, the emergency declaration for COVID will be lifted. I think that's the other piece that we're going to see is, right, governments, be it at the federal or state level or local level, where some of the requirements have been in place for masking or similar risk mitigation measures are going to go away. And so that's really what makes thinking proactively about which ones do you want to keep and when you might reinstitute them as an individual business, I think is going to become critical, because you're not necessarily going to see or get that guidance from either the state or local government or public health authorities going forward. So, we've certainly, I think, been through the worst of the pandemic. And, at the same time, we need to sort of figure out what's a tolerable level of illness within our workforce, and how do we make sure that, we do have appropriate measures in place when we need them. I mean, I think that the other reality that we continue and have to think about contending with, at least as it relates to COVID, is we haven't, by and large, completely gone to, an unmasked environment or, a fully staffed, populated environment. In some instances, some companies that we work with have, but, when we sort of go back to normal, the way things were, say, in 2019, and we still have a circulating respiratory disease that's really highly transmissible, we are going to see cases of illness, and we are probably going to see clusters of illness and outbreaks within the workforce. And so thinking about how you build your systems and respond to that, I think, is going to be key and important. And, part of that too gets to, messaging. How do we communicate that to our workforce as well? So just some thoughts there. We do have a question from someone that says, with a mask mandate no longer in place, how does this affect workers' compensation liability for every team member who gets COVID in the workplace? That's a good question. I think what we've seen, and that, that may vary somewhat from state to state. And I will preface this, I'm not an employment attorney, so not an expert per se in that space. But, when we think about making sure that there are appropriate precautions so that hazards are minimized in the workplace, I think that's that's one frame of thinking to think about developing some of these programs. So what would the community rate of transmission need to be, or say the hospitalization rate in your community need to be, or the illness rate in your workforce be before you start to reinstitute things like masking. So where in some states you sort of have that coverage because the state themselves put that in place, I think the scenario that we want to avoid from a workforce standpoint is someone comes to work actively symptomatic, they're working in close quarters with others, think back to those 3 C's that we talked about at the beginning of the presentation, and you create, kind of your own super spreader event. Again, we have a variant that causes more mild illness, but if somebody hasn't been exposed or vaccinated before, we know that, it can still cause significantly severe illness. We still have over 1,500 deaths occurring in the US associated with COVID every day. So, there is still the potential for severe outcomes depending on the individual. And I think that's also part of the risk communication, that you can provide to your workforce, is that, while masks might not be required anymore, there certainly can be optional for those that choose to wear them. And certainly some people, if they're immunocompromised or have someone at home who's immunocompromised, can certainly benefit from continuing to wear a mask in the workplace to reduce their risk of infection. So part of that really, I think, comes down to that criticality of messaging and making people feel like they have choices. I mean, I think that again, going back to the beginning of the presentation, is what we've seen is that if you give people good information and trust them with that information, by and large, they'll make good choices, and if you can help them interpret some of that data and information along the way, all the better.
Yeah, if I could just add, I do think, having been in the food industry for a few decades, it's always struck me as a very collaborative industry, with people reaching across, and out of their function to others, cooperation between operations and quality food safety folks, for example. I think this question highlights, that before these policy changes are made, there needs to be consideration of things like liability of these kinds of things. So making sure that your legal team is involved in considering the potential risks to making some changes is certainly important, and would want to be consulted in this kind of decision as well.
So I know we're at about time. I don't see any other questions, but I want to thank everybody for attending. And certainly, if there are questions that you have that come to mind after the presentation, certainly feel free to reach out to either Ruth or myself. Our email address is down there. We're happy to field that and answer it. I think we are, in an exciting time, but also, like I said, a potentially challenging time, especially as we see government sort of step away from giving explicit guidance. And so that sort of puts us in a space where we need to think about, what is the best approach to some of these complex problems, kind of at an individual company level or facility level or location level. So I know that can be tricky. So appreciate your time today. I know it's valuable, and it was a pleasure to present. So thank you very much, and reach out if you have any questions. Thank you, Ruth.
Thanks, Ben.